Okay, thanks for having me and giving me an opportunity to talk about some of the work coming out of the Fox lab recently. So to start, historically, the management and treatment of wounds has long been an integral part of medicine since Galen's theory of laudable pus in 200 AD. And it continues to be an important part of our practice due to wounds' high prevalence and high associated costs. Now, we commonly categorize wounds as acute or chronic, with chronic wounds lasting for 4 weeks or longer. And in 2018, it was estimated that over 8 million Medicare beneficiaries suffered from these chronic wounds, and the associated cost of treating them was over $96 billion in healthcare expenditure. So why are these chronic wounds particularly hard to treat? Well, a big reason is because they have a high prevalence of these biofilms. So what are we currently doing to treat biofilms? Well, if you talk to any patients who have chronic wounds, we need to be doing a lot better. They have to come in multiple times a week for dressing changes. They're subjected to painful wound debridements. And if we see signs of infection, we treat with oral antibiotics that we already know have poor penetrance and are associated with their own slew of adverse effects. So in summary, we have this big problem that decreases the quality of life of millions of our patients and costs billions of dollars of healthcare spending. It's a great opportunity for medical innovation. So what do we know? Well, we know that historically hydrogels have long been proven and studied as an effective modality for delivering drugs to patients. Additionally, collagen hydrogels have been proven to expedite wound healing in uninfected wounds. So if we know that these hydrogels can deliver drugs to patients and that collagen hydrogels can improve wound healing, well, then maybe by loading antibiotics onto these collagen hydrogels, it'll be the perfect tool to tackle this big problem. So we started previously with an in vitro attempt. So on the left here, we see a biofilm grown in vitro treated with collagen hydrogel alone. And we see that the biofilm persists. On the right, we see the same biofilm grown in vitro treated with collagen hydrogel embedded with antibiotic. And we see a near complete resolution of the biofilm. The next thing we did that was interesting is we took actual samples from the biofilms present on human chronic wounds, grew them in an in vitro setting, and then used a modified Kirby-Bauer assay to assess for the creation of a zone of inhibition. And we got really great results from all of these. We repeated this with multiple different samples from multiple different patient types of chronic wounds and elicited zone of inhibition in all of them. So we had this idea and we looked in vitro and got really promising results. The next step is to take it to in vivo. And we wanted to do this in a murine model. And we did this with a 2-part study. So the first part, we used the opportunistic bacteria Pseudomonas as our biofilm model and gentamicin as our treatment. Figures A and B at the bottom show dorsal stented wounds created on all of the mice in our study. And figure C shows the experiment schedule. So briefly on post-op day 0, we created wounds. On post-op day 2, we inoculated the wounds with Pseudomonas biofilm, all of those except for the control group. And then treatment began on post-op day 4. We treated one group with collagen hydrogel alone and one group with collagen hydrogel embedded with gentamicin. We changed these gel dressings on an every other day schedule until the date of wound harvest. So to ensure the accuracy of this in vivo model, we wanted to make sure that we were delivering these biofilms that we were growing in vitro effectively to the wounds, and that they were also persisting many days after inoculation. And so the image on the top here shows a infection-only wound on post-op day 12, so 10 days after inoculation, and it shows the fluorescent Pseudomonas biofilm architecture in red and DAPI staining in blue. Additionally, we were curious if the amount of bacteria or the bacterial burden would be decreased using the treatment of these gels embedded with antibiotics. And again, it looked like that happened. So the bottom image shows an observable decrease in the fluorescent intensity of Pseudomonas staining between the infection-only group on the top and the infection group treated with gel and antibiotic at the bottom. Once we were able to determine that these biofilms were persisting through our experiment and that locally we were able to decrease the burden of this bacteria using these gels embedded with antibiotics, we're interested in studying the inflammatory markers. We want to know if the mice that we were treating with these gels and antibiotics were actually getting less sick than the infection-only mice. So here across the x-axis, we see date of mouse sacrifice, and on the y-axis, we see inflammatory markers. We found that the infection-only mice had elevated inflammatory markers, especially at the first 2 days of our interest, and then that when we treated these infections with gel and antibiotic, they had a significant decrease and maintained their inflammatory markers within the normal range at all time points in our study. So for part 2 of our in vivo experiment, we wanted to recreate the same experiment as before, but instead of using Pseudomonas, we use the more common and the more virulent bacteria MRSA, treating it with a gel embedded with clindamycin. We had the same stented wound model and the same experiment schedule with minor changes to the date of tissue harvest. Now, our first result came in wound photography. Across the top here, we see the different treatment groups, and then going down on the y-axis, you can see the date of wound photography. The main finding that came out of wound photography was that there appeared to be an increase in wound exudate seen in the infection-only wounds as compared to the wounds that were infected but treated with gel or gel and antibiotic. To further investigate this, our first statistic of interest using histology was the inflammatory tissue thickness. So across the x-axis of both of these, we see the treatment group, and on the y-axis, inflammatory tissue thickness. And what we found on day 8 was that there was significantly more inflammatory tissue thickness in the infection-only group compared to those that were infected and treated with antibiotic or treated with gel embedded with antibiotic or treated with gel alone. Additionally, at day 14, only wounds that were treated with gel and antibiotic had significantly less inflammatory tissue than the infection-only group. So ultimately, the endpoint of treating a chronic wound is the resolution of the wound that comes in wound closure. And that's kind of the gold standard of what we want to see if we're able to accomplish with these gels embedded with antibiotic. And so to do that, we use histology again. And across the x-axis, you see date of tissue harvest. On the y-axis, wound closure percentage. What we found was that at days 8 and 14, there was a significant improvement in the wound closure rate for those wounds that were infected but treated with gel and antibiotic compared to the infection-only group. And additionally, on day 17, only the control mice and the mice that were infected but treated with gel and antibiotic had complete closure of their wounds, and the other two groups did not. So in conclusion, we believe that collagen hydrogels embedded with antibiotic are poised to be a promising advancement in the way that we can treat these biofilm-infected chronic wounds due to their ability to disrupt biofilms and distribute antibiotics. Specifically, we know that these gels can distribute high doses of antibiotics locally without the risk of adverse effects and systemic adverse effects. So finally, we also believe that these gels are highly biocompatible, as shown in our in vitro study and our 2 in vivo studies where we loaded different antibiotics. And this would allow practitioners to specifically tailor antibiotics to their patient's wound microbiome. This would further contribute to the improvement of antibiotic stewardship. So I want to thank Dr. Fox for her mentorship and everyone in the Fox Lab for their help, and all of you here for listening. Thank you.